Welcome to ANA Investigates, a podcast featuring the latest in neurology and neuroscience brought to you by the American Neurological Association. I'm your host, Adeline Goss. This is an exciting moment in the management of a devastating neurologic condition, Huntington disease. As we know, this genetic disease often hits patients at the prime of life and can be haunting for affected families. As we'll discuss today, new developments in biomarkers and therapies for Huntington's are converging into a more hopeful picture for those affected. We'll hear from two Huntington disease experts, Dr. Jee Bang, Clinical Director of Johns Hopkins Huntington Disease Center of Excellence and Assistant Professor of Neurology, and ANA Investigates producer Dr. Bega, Director of the Northwestern Medicine Huntington Disease Center of Excellence and Associate Professor of Neurology. Here's Danny.
Thank you for having me. This is Danny Bega, and I'm here with my colleague, Dr. Jee Bang from Johns Hopkins. Jee, thanks for being here with us on ANA Investigates.
Great to be here. Thanks for having me.
So we're looking forward to having a discussion about Huntington's disease, and I'm going to set that up first by just giving a framework for what Huntington's disease is, but then really explaining why we're having this discussion and why it's exciting to be talking about Huntington's today. So a few things about this condition that make it, I think, really important and interesting to be studying is, first of all, it's a monogenic disease, which means it's the same mutation and the same disease in everybody who gets it. And while there's variability in the mutation length between people, it's the same problem in the same area of the DNA in everybody who has it. And to us as scientists, that means it's a targetable disease in a way that everybody who has the disease should have the same target for a treatment when we eventually have a cure for this condition. And then lastly, this is a disease that's easily identifiable. As I mentioned, we know the gene and we can test for it with a simple blood test. And what's more, we can identify it before symptoms begin. So for all these reasons, this is a great disease for studying a disease modification. And for many of us, we believe among neurodegenerative diseases, one of the ones where the greatest potential for impact exists in our lifetime. And so with that, I think we should start with a discussion about how we've gotten to where we are today, which is a really exciting area with a lot of research in Huntington's disease, a lot of which has started from observational studies where we've learned about the disease and developed opportunities to intervene. So Jee, if you could just tell us a little bit about what's on your radar with regard to observational studies, why you find observational studies in Huntington's disease to be important, and sort of what we've learned from some of those studies.
Right. So in terms of observational studies, we know it's a very important type of study because we really learn about the disease from those with the disease, and following these patients and families over time has given us so much valuable information to learn about the natural history of the disease, different characteristics of the disease, and eventually leading to drug targets. So one study I want to highlight is called Enroll HD, and this is an international observational study, and it has been going on since 2012. It has now almost 20,000 active participants from 20 different countries. And it's open to anyone, meaning those who have tested positive for the HD mutation, those who tested negative for HD mutation, those who have not yet been tested and don't know their status, and controls. And this not only helps us learn about the disease, but it itself serves as a platform for other clinical trials. So, if there's a new clinical trial, participants enroll are already plugged in, so they can be contacted with their permission to learn about these different clinical trial opportunities. And another big advantage of this large observational study is that the data that are collected through the study are available to researchers around the world who are also interested in contributing to HD research.
Yeah, with regard to, we call HD a rare disease, and if you think about how amazing Enroll HD is, HD affects 1 in 10 to 20,000 people, and as you said, it's over 20,000 people that are enrolled in this worldwide. I mean, it really shows that even for a rare disease, with a community that's motivated, you can really do astounding things and create huge databases that I think are so useful. So beyond the work that's being done in Enroll HD, are there any specific work with regard to biomarkers of disease that maybe tie into some of the interventional trials that are being discussed today?
Yes. So predictive genetic testing can identify mutation positive individuals many years before onset of manifest HD, which is symptomatic HD. And so there's really an urgent need for biomarkers in HD so we can track disease progression and to evaluate efficacy in therapeutic trials. And so there have been a lot of really interesting and exciting discoveries within the HD biomarker research world. And I want to mention two of them. One is the mutant Huntington. Mutant Huntington is what's believed to cause the symptoms of HD. And we are able to actually measure the levels in the CSF. And its levels have been shown to correlate with clinical scores cross-sectionally, as well as with other proteins in the CSF, such as tau and what's called neurofilament light protein. And neurofilament light protein in the CSF in HD is elevated in both pre-manifest and manifest HD patients. It's elevated even decades prior to onset. And it's also been shown to correlate with disease stage, motor and cognitive impairment, and functional impairment. So, therefore, having these biomarkers is going to be so important in helping us moving forward with these exciting trials that are coming up.
Thank you. That's really exciting to hear about the work that's being done with biomarkers in Huntington's. I think this should not be underestimated as an importance in the field of actually having something beyond just clinical measures to look at as a sign of an intervention working or failing. So with that, why don't we start to talk about some of the interventional trials, because there are several. And I think just to focus it a little bit, we should talk about the ones that are perhaps farthest along right now, which are the antisense oligonucleotide or ASO trials, and maybe some of the other gene therapies that are going on to target the mutant protein in Huntington's disease, also known as Huntington lowering therapies. So there was a trial that had a lot of press around it that was published last year on a compound called RG6042, which is an ASO. Can you tell us about that phase 1/2 trial and what was exciting about that trial?
Yes, so that was indeed a very exciting trial, very encouraging in a lot of ways. It was a phase 1 trial. It took 46 volunteers, and they received increasing doses of this ASO. So ASO is a short synthetic single-stranded oligonucleotide, and ASOs bind to complementary pre-mRNA targets in the nucleus and lowers the RNA and eventually lowers the Huntington protein in our case. And this is a drug that doesn't cross the blood-brain barrier, so it does have to be delivered intrathecally, and multiple repeat injections are required in order to maintain therapeutic levels. And the study showed that it was very well tolerated in all of the participants, and it showed dose-dependent decrease in the mutant Huntington levels. And at the 2 highest doses they used, they were able to lower the amount of mutant Huntington by at least 40%. And so now there's a very large phase 3 trial going on with the same drug across many different countries, at least 18 countries, almost 800 participants. And we're cautiously optimistic about the results.
Great. Yes, I also share your cautious optimism about looking forward to the results of this trial. We've all been pretty impressed to see how well patients are able to tolerate all these spinal infusions that they're getting for these trials. But moving past ASOs, there's interest in whether we can, number one, deliver treatments directly to the target area in the brain, and avoid having to do repeated treatments. And so this brings us into the next type of Huntington lowering therapies, which is the RNA interference therapies. Can you tell us about RNA interference and a trial that's in development for using a viral vector delivery of for RNA interference?
Yeah, as you mentioned, well, I'll start out by saying that RNAi therapies currently would be injected directly into the brain tissue. And so different patients feel differently about whether they want multiple lumbar punctures or brain surgery. So RNA interference or RNAi is a natural process by which RNA molecules target the mRNA for degradation by the RNA-induced silencing complex, which reduces protein expression. So again, kind of like the ASO, it is also targeted at lowering the Huntington protein. And RNAi uses microRNA targeting Huntington mRNA, and it's delivered via a recombinant adeno-associated virus or AAV. So this combination of the microRNA and AAV is what's injected directly into either the striatum or other targeted areas. And the recombinant AAVs, which are the vehicles that carry this microRNA drug into the brain, they themselves don't integrate into the host genome, but they remain. In other words, it results in stable gene expression. So it's like kind of like having a little drug producing machine in your brain. So it may, if it works, it may just require a single administration, and you'll have continuous reduction of this Huntington protein. And there's a current trial that has administered this type of drug for the first time in a human. And this just happened back in June. It's a phase 1/2 randomized study. So patients either get a sham surgery or a one-time striatal injection of the drug. And there are other studies using different types of recombinant AAVs. And they use slightly different targets in the brain as well, which have not yet started, but are close to getting started.
Yeah, at the time that we're having this discussion, there have been at least 2 subjects who have already received this treatment in their brain, and this is a slow study because they have to follow people, make sure that the first patient and then the second patient are tolerating it before they continue to proceed with more subjects. But really great to see that these are progressing. I think that that we could be discussing disease-modifying trials for HD for a long time, actually, with the pipeline that is in existence right now, both preclinically and clinically. There are monoclonal antibodies that we haven't spoken about, some of which are large trials which have recently completed and for which data is expected actually quite soon. There are DNA targeting therapies in preclinical models, things like CRISPR-Cas9 for gene editing, trials to look at symptomatic treatment of a lot of the troublesome unmet needs with regard to day-to-day life in Huntington's disease. And so I think the point, though, is that this is a big turning point in Huntington's disease and in neurodegeneration in general. With regard to Huntington's, it's the first time that the drugs are being developed specifically for the disease. They're not just being repurposed, but they're being designed to target the problem that we know exists in everybody with HD. There are a lot of organizations and companies that are investing in HD research and care. We really understand the disease better than we ever did, and we understand the genetics of the disease better than we ever did. And people are participating in trials, both observational and clinical trials, in huge numbers for a rare disease. We have more effective ways to measure the treatment effects than in many other diseases with biomarkers. And we actually have treatments that have shown target engagement and ability to impact biomarkers in human phases. And so this is the reason for all the excitement in this disease, and as a potential model for treating other genetic diseases and neurodegenerative diseases. In your opinion, looking through the panel of options and the pipeline in the disease, is there one that just stands out to you as likely to be the most effective way to intervene in Huntington's disease? What are your thoughts on that as sort of to leave us with?
Yeah, so it's hard to pick out one single therapy that is most promising because in a lot of different ways, all of these therapies we've discussed are very promising and exciting. And in principle, the DNA-based therapies could be the ultimate way to shut down the mutant Huntington production. But in the end, we might really wind up using a combination of these different therapies. So a multifaceted approach may be the way to go.
Well, thank you, Jee, and thanks to everyone for your attention.
Thank you.
That was Dr. Jee Bang, Clinical Director of Johns Hopkins Huntington Disease Center of Excellence, interviewed by ANA Investigates producer Dr. Danny Bega, Director of the Northwestern Medicine Huntington Disease Center of Excellence. Thanks for listening to our show today. To hear more episodes of ANA Investigates or to submit ideas for future podcasts, just go to myana.org and click on the Education tab. For ANA Investigates, I'm Adeline Goss.
This has been an episode of ANA Investigates, the official podcast of the American Neurological Association. Thanks for joining us for this episode. If you're not already a member of the ANA, please visit myana.org to learn more about the benefits available to ANA members, including access to an array of educational programs and resources, like online CME courses, webinars, the ANA's journals, the Annals of Neurology and the Annals of Clinical and Translational Neurology, and more. Dr. Adeline Goss is our host. Our producers are Drs. Romer Giucaden, Adeline Goss, Michelle Johansson, Clifton Gooch, Danny Bega, Megan Ritchie, and Jim Sigler. This is your editor, Jen Hurley. Copyright, the American Neurological Association.